Tēnā koutou katoa, I'm Rebecca Macbeth, and this is eHealthTALK NZ. This episode is part of a collaborative podcast series with Blind Low Vision New Zealand, and today I'm joined by Tori van Loewenhout and Cain Richardson to discuss Blind Low Vision New Zealand's IDI project, which is looking at life outcomes for people who are blind or low vision in comparison to the general population. So welcome on the show, Tori and Cain. To start us off, can you each introduce yourselves and just tell us about your roles in the project?
Hi, my name's Cain Richardson, and I'm a policy analyst at Blind Low Vision NZ. I've been working here for about 2.5 years, and I joined as a client intern. So I have a rare inherited genetic eye condition called X-linked choroideremia, which will end in my eventual blindness. My role in the project was I came up with the idea to do it from my experience looking at the historic research that Blind Low Vision has carried out and its different historical iterations. And I spent a bit of time working in a minister's office as part of my internship, and I got to see some of the research that the Social Wellbeing Agency was doing at the time into veteran outcomes. And I was like, oh, what happens if we could do that for blind people? And this kind of got me started on the investigative course, and which ended up leading to partnering with Nicholson's.
Great. And Tori?
Kia ora. My name is Tori van Loewenhout, and I'm a senior data scientist at Nicholson Consulting. I have been here for about 5 years almost, and for most of that time, I have been an IDI researcher. My role in this project was primarily leading the IDI analytical and reporting phase, working in concert with Cain and my colleagues Sarah and Todd to produce a piece of work that I'm really proud of.
Great. And so can you tell us what was the motivation behind starting this IDO project? What is it, and why was this population in particular important to focus on?
The motivation in starting it really was that the only information we have sort of on our population and then essentially what their lives look like is kind of first and foremost is our own client data. So the records we keep for our members and clients, and then like the only external research we have is mostly sample surveys. And the IDI was essentially a powerful population-based tool. It was very attractive to go on a bit of a data quest to find blind people and the different little pieces of admin data that exist and to look at what their lives look like.
A big motivator for us doing this work and taking this on was the ability to increase accessibility to disability data as a whole in the IDI, and making it more accessible for other researchers to take a population group such as blind and visually impaired people, and be able to use that in their own research that further contributes to the evidence base, and it creates like a snowball effect where one piece of research will lead to an idea for somebody else, and then that will lead to an idea for someone else. And when you have a foundation, it gives everybody the same starting point and common reference point that was done in a robust way.
Would it be fair to say that the problem was that this population was invisible in terms of who they are and also how they're progressing in life, what services they're accessing and what outcomes they're having? So you wanted to be able to tell the story of this population.
Yeah, it's exactly what we wanted to do. Like we essentially, blindness itself is an invisible disability, right? Blindness and vision impairment and low vision. And we wanted to put some sort of quantitative analysis and be able to tell the stories that our clients told us through data to essentially build an evidence base to better understand who we serve and to use that to lobby the government for funding for services to produce better outcomes.
Yeah, it's so important to have the data to back you up these days, isn't it? So you've both mentioned the IDI. Just for anyone who isn't familiar with it, what exactly is the IDI, and how does the linking across all those data sets, some of them you've mentioned already, actually work?
So the IDI is the integrated data infrastructure, which is maintained by Stats New Zealand. Essentially what it is a central repository of administrative data from across government agencies, some non-government too, but primarily government agencies, and then also surveys, many undertaken by Stats, such as the census and the disability survey, but also other surveys. And essentially it's linked microdata. So there's individual unit records at a person level. And this is linked from one agency to another to, survey data on the spine. And so the spine is essentially a construct that's meant to represent everybody who's ever been or lived in New Zealand. And it's made up of birth data, tax registration data, and visa applications. So this is like the central core. And then each individual data set that comes into the IDI is connected to the spine on personal details, such as like an IRD number or an NHI number, first name, last name, birth date. But that is then all removed and de-identified so that you don't know who a person is, but you can link that person across different data sets to get a fuller picture. And so it allows you to follow somebody's journey from, the time they're born or even when they're a fetus inside a mother, like through education, employment, their income, their health, justice, aged care. And it's amazing in that, this is pretty unique globally, and it allows basically an unprecedented opportunity for some really amazing research.
Well, it sounds like a hugely powerful tool that you've got at your disposal here. Can you just give an overview of the Blind Low Vision project, what it set out to do and how you went about getting it started?
We wanted to do two things in the beginning. Was one, to identify a population, and then second was to look at their life course outcomes. I first had a conversation with a couple of friends that have done RDI research in the past to try and sort of navigate the environment to figure out what I didn't even know, and then had a conversation with Stats NZ about different options, whether we wanted to do a customized data request or we wanted to do RDI research ourselves, and then went through essentially business planning phase, how we evaluated whether we wanted to do the research ourselves internally, to dedicate the kind of resources to do that, whether we wanted to use an external agency like the likes of Nicholson's and talk to a few different providers, figured out who we wanted to go with. And we ended up partnering with Nicholson's because they have quite a lot of experience working with charities. They're a for-purpose organisation. And they've done quite a bit of work recently in disability data, which really interested us, which helped us navigate our research a lot easier. And then we essentially went about writing a microdata application with Nicholson's, and they were great. Like Tori and Todd helped us navigate the whole application process from beginning to end.
Yes, so the microdata application process, it is a step that you have to go through every time you want to set up a new project in the IDI environment, and it's to ensure that Stats is protecting people's data, which is obviously very important, and because there's a lot of trust in that. So we have to be very clear about what our research questions are, what data we are wanting access to, and for what reasons, making sure that there has been engagement with the population of interest that you're researching so that you're not doing things to populations or for populations, but with them. And it's about making sure that the researchers have the adequate skill set to safely work with the data and have the training to confidentialize it to the standards that they require.
And so once you do get that access to the IDI, what does the actual research and analysis involve? What were you looking for in this project, and how did you go about actually identifying people in the blind and low vision population?
So basically, when you have access to the IDI project, you're starting from a blank slate. So you have access to the source data, of course, but you will then need to understand how to work with it and what variables you will need to then code up or program a piece of work that applies business rules to get a population or to get an output that meets your requirements. So basically, we started with a scoping phase. Sarah and I worked with the data to understand what is even available. And then, and we worked with Cain throughout this time as well, like to basically commission out the code module, which is the base of our work, of who are the blind and visually impaired people in New Zealand and how can we identify them? What avenues can you go through? Where is there gaps in the data? And how can you fill those gaps? And so at each point, like, is there where someone interacts with a government agency? Is there a reason for that? And is that data available on that reason. So, for instance, with that supported living payment for health condition and disability, that has corresponding incapacity codes. And they had to have an incapacity reason of blindness or low vision. And so it's working out all those business rules and then also getting input from experts on like medical coding and things like that to understand what diagnosis codes should be included. For instance, with the severe visual impairment indicator, what makes somebody's visual impairment severe compared to not severe?
What about from your perspective, Cain? What was the process of actually doing the research and finding the population? And you've talked about what was the available data. So what were some of the gaps or limitations you encountered in that data?
Essentially, I had a rough idea when we began of data points we wanted to use. And then we did a bit of a plan with Nicholson's, and then they went off and did some exploratory analysis, and they found a bunch of things we didn't even think of. And then there were some limitations to the things that we thought we could use. Like when we get into health data, like looking at ICD-10 codes and all the historical variations of it, there's a lot of different codes when it comes to eye conditions. Because within ICD-10, there is injury and disease codes that diagnose a sort of condition or an injury or a disease. But then there's also a set of codes in there, sort of described as outcome codes. So like what did that condition result in? We decided at that point to just include the outcome codes, and then we'll kind of sort through the disease and injury codes next year when we update the code module. And sort of the same when we sort of searching through ACC codes. There's a lot of codes, but not all of them are that useful because you're not really capturing congenital conditions within ACC. It's essentially all injuries, right? So there was like one of the random codes we came across was a legal blindness in the United States of America code, and so we know what that is in terms of an acuity definition, so we included it. So that was some really interesting analysis.
It's also important to note with that we only have these codes for people that got these diagnosis codes or outcome codes through like the DSS system or ACC or through a publicly or privately funded hospital event. But if you were diagnosed in a GP's office or like an ophthalmologist that's not associated with a tertiary hospital care, then you're unlikely to appear in this kind of diagnosis data. And that's where we would have tried to capture you in another way through supported living payments or ongoing resourcing schemes or before school checks. But there are those missing gaps. So someone was diagnosed earlier, like just at their family GP. It might not necessarily have been captured.
And that kind of was interesting, like the different sort of coding systems used between a lot of the health and disability providers. Like ACC is still using ACC read codes, which are based on a system that was of health coding that was developed in the UK, which decades ago, which no one's really using anymore. And then they're transitioning to SNOMED, which they'll use as their sort of clinical coding system, where the health system uses ICD-10 and the disability support system uses a bespoke Socrates system. So like all these three systems which are dealing with the same thing, but are describing it in very different ways. And it makes it pretty hard to make sense of it within the data, right, Tori?
Yes, there was definitely challenges, and it was a matter of documenting it as well in a really succinct and clear, transparent manner so that users would know exactly what we're working with. And then there's always, the ability to improve the module and improve the analysis in the future when underlying source data changes.
Given the issues around coding that you've spoken about and standards, what did it reveal to you about the need for more consistent coding systems across health and government data sets in order to be able to identify people and their journeys through various systems?
It would definitely be helpful if the same standards existed across all government agencies to have the same coding systems and standards, because then you would be able to better identify the same diagnosis and have a better idea of kind of the onset of visual impairments. Whereas you might have, one coding standard that gives you a diagnosis code in one system, it gives you another one in another system. And because they're not necessarily referring to the same event for diagnosis. You're not 100% sure like which is the most current state or the most appropriate, or if there's varying levels of blindness, like what one would you choose?
So one of the interesting outcomes that you've both mentioned is this reusable code module that you're going to release. Can you tell us what is that and why does it matter?
The code modules are about democratizing like access to the data, and like creating like a framework and standard for indicators and measures that are quite well used across different government agencies for government and non-government research to give everybody the same foundation and base to start with. With that democratization, it means people who are less familiar with the IDI environment won't necessarily have to have the same level of underlying knowledge to work with this data that would come from needing to consult across government. It means that people who ordinarily wouldn't have the resources to do a widespread consultation can still work with this data and then use it for their own research. And it means consistency. People are using the same rules. So you're able to do more like time series analysis because you know that you're talking about the same people and the same population. And one of the big benefits of the modular coding process is the documentation that comes alongside it.
And so in terms of the process, Cain, from what I understand, you've completed the research and analysis and are now collating the report. That obviously hasn't been launched yet, but can you give the listeners any small hints or some teasers about what you've actually discovered?
We've finished the report now. Nicholson's finished writing it. They've done an amazing job. And we're just editing it now to send it off to our alternative format services to get it turned into like Braille format, audio. We're going to publish it as a web page, an HTML web page, so it's as accessible as possible for our members to essentially democratize information about them, to empower them with knowledge for self-advocacy, right?
We do a fair bit of similar work in this vein of outcomes across people's life course for different subpopulation groups. And I was surprised about the level of inequity experienced by people who are blind and visually impaired.
The report was great for us in the sense that it was extremely well done and we are happy to see it finished, but all of the outcomes reflected a lot of the anecdotal information we've heard over the years. Like employment was as bad as we've thought it was, actually slightly worse than some of our own qualitative surveys over time have suggested. There was one upside, which is that the population we identified had slightly better secondary school outcomes than the general population, but the not achievement and post-secondary school outcomes are all terrible in terms of education achievement.
Now that you have the data to back up what you've been saying for a long time based on anecdotal evidence, what are you hoping this research could actually lead to in terms of change?
Yeah, well, we're hoping we can bring some change in terms of improved outcomes, especially over some of the main categories of life. Like employment is one of the huge ones that we'd like to see improvement in, because numbers really haven't changed over time, over 30, 40 years. That's like, well, what new ways do we need to start thinking to get people into employment to change their life outcomes? Because sort of employment and vocation are sort of the foundation for everything, really, in terms of the rest of the outcomes, in terms of housing, income, well-being is the foundation to them all.
What about you, Tori? What are the sort of the next steps after a big research project like this in your experience? And have you seen it lead to change perhaps in other areas that you can talk to?
I have seen having a solid evidence base lead to actual positive change where that data is the basis for policy that does seek to improve people's outcomes. I think there are definitely places where you could look at intervening with, programs or policy to have meaningful impact on somebody's trajectory towards severe visual impairment or visual impairment in general, and then to the outcomes they experience, maybe closing loopholes of people who fall through the gaps where they might not necessarily qualify or be eligible for certain services, but they're still experiencing the same deficits that people who get those services experience, but they don't meet that criteria. I also hope it leads to future research to look at things like causality, that real first step towards work that could assign causality from exposures through to outcomes.
It sounds like, you said that IDI is quite a unique tool internationally as well. So this kind of linked research that looks at life outcomes and life trajectory from cradle to grave ultimately. Are you hoping you're going to get some global interest or recognition around this as well in terms of, interest from other countries?
Yeah, we definitely are. I was in the UK earlier in this year and had a conversation with some staff members from the RNIB, the Royal National Institute for the Blind in London, and they were very interested in what we were doing because essentially government information in the UK is so isolated. It's not integrated in a system like ours. So like the ability to just be able to identify a population in a sort of data set that's all in one place and is essentially accessible but also highly secure and protects the identity of the individuals that are in there is extremely powerful.
Well, we'll certainly be following it with interest and look forward to the launch event in February and hearing about the outcomes of the release of the code module in March as well. So we do have to wrap it up though. So thanks, Cain and Tori, so much for sharing the story behind the project. I know our audience will appreciate what goes on behind the scenes in a research analysis like this. And to our listeners, be sure to like and subscribe to this podcast to make it easier for others to find.